Renal tubular acidosis, RTA, is a clinical syndrome characterized by hyperchloremic metabolic acidosis with a normal serum anion gap. The primary impairment is the excretion of fixed acid distal RTA, or the reabsorption of filtered bicarbonate proximal RTA. The acid retention or bicarbonate loss results in hyperchloremic metabolic acidosis marked by low serum bicarbonate and a normal anion gap. Either hypokalemia or hyperkalemia may be present, depending on the nature of the acidification defect. Fanconi syndrome is due to dysfunction of the renal proximal tubule, resulting in the urinary loss of substances normally reabsorbed by the kidney at this site, such as bicarbonate, glucose, amino acids, phosphate, small proteins, and uric acid. Salt wasting, volume depletion, and potassium wasting often develop as secondary effects. There are 4 types of RTA. Type 1, classic distal RTA, due to distal hydrogen ion secretion defect. Type 2, proximal RTA, due to proximal convoluted tubule defect and bicarbonate reabsorption. Type 3, a rare combination of proximal and distal RTA caused by carbonic anhydrase cyclin deficiency and carbonic anhydrase inhibitors blocking the metabolism of bicarbonate and carbonic acid. Type 4, hyperkalemic distal RTA, due to mineralocorticoid deficiency. Causes of classic distal RTA type 1. Primary, inherited. Autosomal dominant, mutations of the SLC4A1 and E1 genes, which code for chloride bicarbonate exchanger proteins. SLC4A1 mutations can occur with either autosomal dominant or autosomal recessive transmission. Acquired. Systemic diseases, autoimmune disease including Sjogren's syndrome, primary biliary cirrhosis, and systemic lupus erythematosus. Drugs, amphotericin B, lithium, immunotherapy, and high doses of ibuprofen. Tubulointerstitial disease, obstructive nephropathy, nephrocalcinosis, medullary sponge kidney, hyperthyroidism, milk alkali syndrome, and vitamin D. Proximal RTA, type 2, causes. Primary, inherited. Autosomal recessive, mutation in SLC4A4, the gene encoding electrogenic NBC1. Low syndrome, X-linked disorder characterized by cataract, intellectual disability, and Fanconi-like proximal RTA, results from a mutation in the OCRL gene. Fanconi-Bickel syndrome, an autosomal recessive disorder characterized by proximal RTA and impaired utilization of glucose and galactose. Dense disease, X-linked recessive disorder characterized by low molecular weight proteinuria, hypercalciuria, nephrocalcinosis, and nephrolithiasis caused by mutations in either the chloride channel gene, CLCN5, or the OCRL gene. Familial, cystinosis, Wilson's disease, acquired, light chain disorder amyloidosis, multiple myeloma toxins, lead and cadmium drugs, tenofovir, valproic acid, and carbonic anhydrase inhibitors, e.g., acetazolamide, methazolamide, and dichlorphenamide. Mixed proximal and distal RTA, type 3, causes. Inherited carbonic anhydrase 2 deficiency, carbonic anhydrase inhibitors, e.g., topiramate, acetazolamide, methazolamide, and dichlorphenamide. Hyperkalemic distal RTA, type 4, causes. Hyperkalemic distal RTA, type 4, causes. Hereditary hyperkalemic RTA, inherited hypoaldosteronism due to congenital isolated hypoaldosteronism, pseudohypoaldosteronism, type 2, Gordon syndrome, or resistance to aldosterone action seen in type 1 pseudohypoaldosteronism, acquired hyperkalemic RTA, diabetic kidney disease or chronic interstitial nephritis, obstructive nephropathy. Drugs, potassium-sparing diuretics, trimethoprim, pentamidone, nonsteroidal anti-inflammatory drugs, NSAIDs, calcineurin inhibitors, angiotensin inhibitors, and heparin. Presentation. In adult patients, the diagnosis of RTA is more often made after the observation of unexplained, incidental laboratory findings in blood and urine acid-base parameters and electrolyte concentrations. Rarely, patients may present with severe acidosis and Kussmaul's breathing due to respiratory compensation and muscular weakness. Paralysis may be present due to hypokalemia. In children, the diagnosis is commonly identified following an investigation for growth retardation, rickets, or failure to thrive. Classic presentations of RTA: the combination of growth retardation or renal rickets with hypokalemic, non-anion gap metabolic acidosis, and very low serum bicarbonate in a child indicates proximal RTA, type 2, or a hereditary distal RTA, type 1. Hypophosphatemia, glycosuria, and excretion of amino acids in the urine is suggestive of Fanconi syndrome with proximal RTA. Rarely, multiple myeloma may be associated with Fanconi syndrome and proximal RTA. Hypokalemic metabolic acidosis combined with osteopetrosis suggests a mutation of carbonic anhydrase. Carbonic anhydrase 2 deficiency presents with bicarbonate wasting with inability to lower final urine pH. Hypokalemic non-anion gap metabolic acidosis with sensorineural hearing loss suggests classic distal RTA, type 1, but does not distinguish between the major responsible mutations. In adults, classic distal RTA should be considered in patients with nephrolithiasis and nephrocalcinosis and evidence of hyperchloremic metabolic acidosis. Patients with nephrocalcinosis and nephrolithiasis in the absence of a known cause should be evaluated for incomplete distal RTA. The acid-base status and serum potassium in adult men with partial urinary tract obstruction should be carefully monitored. Depressed serum bicarbonate here may indicate mild hyperkalemic distal RTA. Investigations. All RTAs have low arterial pH and low bicarbonate with high serum chloride. All RTAs have a normal serum anion gap, but a positive urine anion gap. Only RTA type 4 has hyperkalemia. Other RTAs have hypokalemia. Only RTA type 1 has high serum calcium. Management. Alkali therapy is the mainstay of treatment in all forms of RTA. Type 1, classic distal renal tubular acidosis, treatment acute, correct hypokalemia before acidosis. Chronic, oral bicarbonate, long-term potassium supplements are usually not required, as alkali therapy prevents excessive urinary potassium loss. Alkali replacement therapy is given to correct metabolic acidosis and to maintain serum potassium levels in the normal range. Dose of alkali begins at 1 mmol per kg and is increased as needed to achieve normal serum bicarbonate. Severe potassium deficits should be at least partially corrected before beginning bicarbonate administration. Any one of many solutions may be used. Shoal solution is generally the most accepted. Potassium-containing variants of shoal solution should be used when there is a significant potassium deficit. Potassium supplements. Classic distal RTA typically presents with significant potassium deficits and ongoing potassium losses in the urine, owing to the effects of hypokalemia on cardiac rhythm, nerve, and muscle function. Attempts should be made to correct potassium balance to normal. The serum potassium should be checked at intervals and therapy adjusted as needed. Although unlikely to occur, over-replacement or too rapid replacement could result in hyperkalemia. Infusion rates of greater than 10 mmol per hour should be used with caution in patients with extremely low potassium levels. Type 2, proximal renal tubular acidosis. Treatment. Treatment is intended to correct acidosis and to maintain a serum bicarbonate concentration at a near normal level. A large amount of bicarbonate is usually required to correct the acidosis. High doses of bicarbonate are required, but the prognosis is good. Correcting acidosis and low potassium levels allows normal growth and prevents bone disease. However, vitamin D supplements may also be required. Hydrochlorothiazide can be added to create mild volume depletion and increase proximal tubular resorption if bicarbonate level fails to rise. However, if this is done, potassium supplementation needs to be increased. Potassium excretion is increased by bicarbonaturia. Therefore, a combination of sodium and potassium salts is often used to treat this disorder. If serious hypokalemia is present, it may be necessary to replete potassium stores before giving large doses of alkali. Consider hydrochlorothiazide. The defect in proximal bicarbonate reabsorption in proximal RTA is profound. Simply replacing alkali by oral supplementation can be very difficult because of the unpalatable nature of the solutions used. Hydrochlorothiazide has been used as a supplemental treatment. It, or any other thiazide diuretic, can be used to induce a state of volume contraction, which, in turn, stimulates overall proximal reabsorption. Proximal bicarbonate reabsorption increases as overall proximal reabsorption increases. This effect helps to raise the serum bicarbonate. However, the state of volume contraction induced by thiazide diuretics stimulates aldosterone secretion and increases the distal nephron secretion of potassium. Thus, potassium losses worsen and may result in severe hypokalemia and potassium depletion. Potassium supplementation is always required when thiazides are used in proximal RTA. Type 3 renal tubular acidosis. Treatment needs to be individualized to the patient's biochemical status, depending on whether proximal or distal renal tubular acidosis predominates. There is no specific treatment for this type of RTA. Alkali replacement therapy is given to correct metabolic acidosis and to maintain serum potassium levels in the normal range as required. Severe potassium deficits should be at least partially corrected before beginning bicarbonate administration. Any one of many solutions may be used. Shoal solution is generally the most accepted. Potassium-containing variants of shoal solution should be used when there is a significant potassium deficit. Type 4, hyperkalemic renal tubular acidosis. Treatment: fludrocortisone is required if there is acidosis or hyperkalemia. Fludrocortisone 0. to 0.3 milligrams per day orally. Hyperkalemic distal RTA, type 4, mineralocorticoid deficiency. In some patients, correction of potassium deficit may improve ammonia production to the point that acidosis improves significantly. Drugs known to be associated with hyperkalemia should be discontinued. Patients should avoid salt substitutes containing potassium and should follow a low potassium diet. Fludrocortisone should be given with caution in special situations such as the need to avoid mineralocorticoid. Administration to patients with congestive heart failure or hypertension. When the serum potassium level is controlled, there will often be an associated improvement in the acidosis by increasing ammonium excretion. In patients with hypertension, heart failure, or advanced age, the use of fludrocortisone may result in excessive sodium retention and exacerbation of hypertension or edema. Potassium levels should be monitored. Treatment is lifelong. Sodium alkali therapy. Alkali administration may be needed if correction of mineralocorticoid deficiency and potassium balance do not restore the serum bicarbonate to normal. Hyperkalemic distal RTA, type 4, mineralocorticoid resistant, loop diuretic, furosemide, 20 to 80 milligrams orally once or twice daily, potassium restriction, increased salt diet. Patients should avoid salt substitutes and drugs containing potassium and should follow a low potassium diet. In these patients, the aim is to increase urinary potassium loss by using loop diuretics, which directly inhibit potassium reabsorption in the loop of Henle. Potassium losses due to the diuretic can be increased further if sodium in the diet is not restricted or even encouraged. However, because many of these patients are older and have some degree of renal insufficiency, their blood pressure and state of sodium balance must be monitored relatively closely. Attention must be paid to the patient's volume status. Volume depletion and volume overload should both be avoided. Potassium level should be monitored. Sodium alkali therapy. In addition to the measures to correct potassium balance, patients may also need to take alkali solutions to improve acid-base balance. Potassium-containing solutions should be avoided. Thus, shoal solution is the primary therapy here and should be titrated until serum bicarbonate is normal. Consult specialists for further guidance on dose.